Together, we're going to explore why some patients fare better than others and what can be done about it. And some of the aspects discussed will include data on ethnic diversity in fertility treatment, which has been published by the UK's fertility regulator, the Human Fertilisation and Embryology Authority. First speaker this evening is Baroness Geeta Nargund, and she is a member of the Human Fertilisation and Embryology Authority and founder of the Health Equality Foundation. She's also Pro-Chancellor of Health Equity at the University of Portsmouth and a member of the International Advisory Board for Lancet Obstetrics, Gynecology and Women's Health. She was previously the lead consultant for reproductive medicine at St George's University Hospital and medical director of Create Fertility and ABC IVF. She's a contributor to the report Fertility, Policy and Practice, a Toolkit for Europe, and co-editor of the book Development in Vitro Maturation for Human Oocytes, and contributor to the Handbook of Current and Novel Protocols for the Treatment of Infertility, and to the book Ovarian Stimulation.
First of all, I'd like to thank Progress Education Trust for giving me the opportunity to participate in this evening's meeting. I'm Geeta Nargund, authority member at the Human Fertilisation and Embryology Authority. As well as being the UK regulator of fertility treatment, we collect data on fertility treatment using our HFEA register, analyze the data, and write reports to share information about the sector and what sorts of trends we are seeing. Today, I'm going to speak to you about what the data is telling us when it comes to patient experience of fertility treatment for patients from different ethnic backgrounds. First, I'm going to start with our most recent ethnic diversity in fertility treatment report. This was our second ethnic diversity report with data going up to 2021. It included an update to key actions to reduce disparities faced by Black, Asian, and ethnic minority patients identified in the previous report, along with a call to action to reduce disparities in access to and outcomes for Black, Asian, and ethnic minority patients. Ethnic comparisons are limited by the data we hold on our register, and there are several factors that may relate to the differences we found in this report. If we look at this particular slide, the average age at starting fertility treatment was higher among Black patients in heterosexual couples at 36 years compared to the national average of 35 in 2021. And this can be related to a number of factors, such as social, economic, and structural factors, but also it could be related to the funding situation in the region. As we all know, we still have a postcode lottery when it comes to NHS funding. If the NHS funding situation in that particular region is different, then it can affect. It can also be due to other factors such as eligibility criteria for NHS funding, such as BMI, and age. If they have actually waited too long to get their pre-existing conditions sorted before starting IVF, it might be too late for them to start. It could be due to their socioeconomic factors where they are not able to afford IVF treatment. But we will be looking into that in further details. When it comes to proportion of cycles that were NHS funded, that was actually lowest amongst Black patients, with only 41% of cycles funded for Black patients. And this is reduced from 60% in 2019. In other words, 60% of Black patients got NHS funding in 2019, and that dropped to 41%. And if we look at the comparison for others in this situation, the proportion of IVF cycles funded was 47% for mixed population, 49% for Asian population, 53% for white population. So that is, once again, something to be looked at, because it's unacceptable that Black patients get less NHS funding. Black patients had the lowest IVF birth rate across all ethnic groups. Their IVF birth rate was 23% versus 32% for white patients aged 18 to 37 in 2020-21. So once again, to have a success rate of nearly 10% lower than white patients is unacceptable. The reasons for this is something, once again, there are no data collected as regards to this particular one, but I think there are some reasons that we could discuss why they could be having significant, nearly 10% lower success rates compared to white patients. When it came to multiple birth rates, the good news is that multiple birth rates declined in all ethnic groups. And the HFA is quite proud to have achieved that, but Black patients continued to have the highest rates at 9%. So these are the disparities that we see, and there are 4 different and important aspects when it comes to access as well as outcomes. And that is something that needs to be discussed and addressed. Not only did this report act as an update to key actions to reduce disparities based by Black, Asian, and ethnic minority patients, but also we published a call to action with some of our key stakeholders, like the Royal College of Obstetricians and Gynecologists, British Fertility Society, patient support organizations, and Royal College of General Practitioners. And with the stakeholders, the idea is to make sure that we work together collaboratively and address this, because these ethnic disparities are unacceptable. So a call to action, when it came to that, the issue has been highlighted and the statement by the HFEA has been published. And essentially, there are 3 key aspects to this call to action. One is development of clinical policies, and that is addressing NICE guidelines as well. And the HFEA has made representation for NICE guidelines that should be coming up soon, the renewed guidelines. So when it comes to deciding referral criteria and for patients from Black, Asian, and ethnic minorities, we need to take into account the disparities and establish early referral criteria in order for them to be referred early and get early intervention and treatment, so that there are no disparities in outcomes. And we also need to improve awareness. We need to improve awareness for patients. We have to consider that there are going to be digitally excluded population as well. So that awareness for patients needs to be specific, tailored at community level, as well as at regional and national level, in order to bring to their attention the need for getting themselves referred early and getting treated early. But also, we need to raise awareness amongst healthcare professionals, because healthcare professionals, including general practitioners, need to be aware that there are these clear disparities in outcomes, and therefore it's our responsibility to address it right at the beginning, from prevention to early referral to early intervention, so that the outcome disparities are reduced. And NHS commissioning. So commissioners need to be aware about their local population. And what I'm delighted to say at this stage is that we know that the waiting lists are coming down, which is great news, which means these patients should be able to get themselves referred early. And the 10-year NHS plan is also going to be implementing neighborhood health hubs at community level. And those should be particularly helping, because they should be tailored to the local population, and that local population, depending on the population, there should be early referrals and early diagnosis. So I am hopeful that with the new 10-year NHS plan, we should be able to address these disparities. Now I want to bring things forward to 2024, when we undertook our national patient survey. We run this every 3 years, and it not only helps to inform about our work, but it also helps us better understand the views and experiences of fertility patients undergoing treatment in the UK licensed clinics. Our 2024 survey ran from 2nd September to 9th October 2024, and it was published on 26th March 2025. The number of patients included in this report was 1,500, and the survey explored the patient pathway from accessing GP services, choosing a clinic, and a number of other factors. And we also have here not only the overall satisfaction rate, but also particularly for Black and Asian patients. So as you can see from this slide, overall 73% were satisfied with their most recent treatment. But when we looked at Black Asian patients, they were less likely to report being satisfied with their treatment. 59% for Black patients and 50% for Asian patients, compared to 73% overall satisfaction. This may relate to lower birth rates. It may relate to lower proportion of NHS funding in their region for these patients. So let's have a look at this in more detail. So if you look at this, the differences in satisfaction were seen with the quality of information, clinic environment, the extent to which they were treated with dignity and privacy, the extent to which their clinic was available to answer their specific queries, and the level of care received by the staff. So in almost all aspects of treatment, both Black and Asian patients reported lower levels of satisfaction than white and mixed patients. So it's quite important that we not only look at the access to and outcomes of treatment, but also patient satisfaction, because the journey is as important as the destination. If we quickly look at the use of donor eggs, sperm, and embryos as well, because the trends and figures report that's published tells us all about the use of donor eggs, sperm, and embryos. So I'm going to cover briefly about the use of donor gametes and embryos. We know from our previous national patient survey that 82% of respondents said that it was important that ethnicity of a donor matched their own. And when asked how easy it was to access donor gametes, you can see here from this slide, 70% of those using donor sperm felt access had been easy, compared to 59% of those when it comes to using donor eggs. Most patients using donor eggs were treated using eggs donated in the UK, arranged through a UK licensed clinic or donor bank. Those using donor sperm were slightly more likely to be treated using donor sperm imported from overseas. However, when we look at this by ethnicity, Asian, Black, mixed, and other patients, that was different. So when it comes to how can we address these, because it is unacceptable that these ethnic disparities remain in healthcare, but in particularly in fertility sector as identified by the HFEA. It's very important that we continue with our call to action and work with stakeholders to address this. Development of clinical policies, particularly factor in ethnicity when deciding referral criteria and policies for investigating and treating subfertility. Improve information and awareness amongst all healthcare professionals so that they take into account the need for early referral and intervention. It's also important that we improve the awareness amongst public and particularly use community health hubs as well as community centers to raise awareness, particularly for digitally excluded patients, state funding for treatment, so that we address eligibility criteria. We work with commissioners because we need more publicly funded research, explore the relationship between gynecological and other health conditions, improve quality of ethnicity data in fertility treatment in clinics. And that is quite important as well, because at the moment, we do need that quality of ethnicity data from clinics. But overall, the positive news is that the waiting lists are coming down. Community health hubs should help with early diagnosis and interventions. But the work of the HFEA with collaborators should also help to improve the situation. Thank you for your attention.
Moving on now to our next speaker, Dr. Patricia Hamilton, who's a lecturer in sociology at the University of York. She was previously a Marie Curie Research Fellow at University College London's Thomas Coram Research Unit. She has written for BioNews about Black people's experiences of care, and she's an author of the book Black Mothers and Attachment Parenting.
So, as Sarah explained, my name is Dr. Patricia Hamilton. I'm a sociologist interested in race and reproduction, and I'm based at the University of York. Today, I'm going to present some early findings from a pilot study, the study that Sarah mentioned, that I conducted last year, exploring Black people's experiences of fertility treatment in the UK. To answer the question that has brought us here tonight, why Black people and other racialized minorities experience poorer outcomes and report lower patient satisfaction. This is going to require different groups of people coming together with different sets of expertise, working together to address what is a major problem, much like this panel today. So, as I said, I'm a sociologist, so I'm going to leave the more medical dimensions of this question to my clinician counterparts. But what I hope to do today is highlight the social dimensions of this problem, the lived experience of navigating fertility treatment for Black people, and highlight why this is an important part of understanding poor outcomes. I'm really pleased that I've come after Professor Nargund because she's set a lot of the context that I want to speak to. So, for instance, some of these experiences that I came across in the pilot study that I did included inconsistent NHS eligibility criteria, high costs of private fertility care, and shortages of Black egg and sperm donors, to name just a few of these challenges. So, as the previous speaker laid out so clearly, we know that there are racial and ethnic inequalities in fertility treatment. Researchers and public health bodies like the HFEA have uncovered clear evidence of these inequalities, and I'll say a bit more about them later on, kind of building on Professor Nargund's presentation. But to fully understand the nature of these inequalities, as the HFEA and the other related fertility-related bodies stated in December 2023, we need urgent research and intervention. While Professor Nargund's presentation focused on more of the clinical and NICE or institution level interventions, I'm going to focus on the call for publicly funded research to explore the barriers that Black, Asian, and ethnic minority patients experience when accessing and going through fertility treatment. To understand how these barriers might influence people of color's poor experiences, I sought some funding to carry out a very small exploratory project. In my review of the literature and other research projects before I started my project, I wanted to see what other research existed out there that focused on the intersection between race, ethnicity, and fertility. And there was very little, and what little I did find was focused on South Asian communities. Now, race and racism manifest in different communities in different ways, reflecting specific histories of migration, discrimination, and resistance. And I wanted to know specifically about the experiences of Black communities in the UK. And as Professor Nargund has presented, Black communities in particular experience heightened levels of inequality and disparity. So the aim of my exploratory project was to lay the groundwork for a larger project later on down the line by identifying the key questions for Black fertility patients and the fertility professionals that they work with, so that Black people's experiences would be at the center of this larger project. With the help and support of many organizations and individuals, Sarah among them, I conducted semi-structured, in-depth interviews with 19 people, 11 of whom were Black women who had currently or had previously undergone fertility treatment. My intention was not just to interview and focus on women, but it was only women who approached me and were interested in participating in the project. As Sarah's introduction suggests, we see that gender shapes the experience of fertility treatment, as some of the speakers will again, no doubt, testify to. But on this presentation, I'm working with the data I have, which focuses on these 11 women whose stories may give us some insight into why people of color's fertility experiences are marked by poorer outcomes. My plan here is to highlight two related themes. Number one, delays in accessing treatment, as already highlighted. But two, and relatedly, how these might be explained by the impact of racism. So as Professor Nargund so beautifully reported, the HFEA's Ethnic Diversity Report published in 2023 found that Black patients tend to start fertility treatment later than other ethnic groups, an average of 36 compared to 35, which is the average age across all heterosexual patients. And as she highlighted, there may be many reasons for this delay. One of the reasons that the HFEA suggested was that it might be explained by a lack of fertility awareness. This can be true both amongst GPs, but also among the communities most impacted. Also highlighted by Professor Nargund is the cost of fertility treatment, especially if, due to that postcode lottery, one is compelled to pursue private fertility treatment. There's also been research that specifically highlights the stigma around infertility within racially minoritized communities, which might discourage people from seeking treatment. But as I suggested earlier, there's been very limited attention paid to the unique experiences of Black communities in the UK who, in some areas, have much worse outcomes than other minoritized groups. For the women I interviewed, stigma and fertility awareness were factors, but many women also emphasized the impact and context of being dismissed by your GP. I'll start with Amelia, who was a healthcare professional in a different field of medicine, who told me that she went to see her GP after her periods became very light. She and her husband had been trying to conceive for over a year, but had not succeeded. Emilia was concerned the two things were connected, but her GP responded that Emilia should be happy that her periods were light after she had previously experienced heavy bleeding caused by fibroids. Despite her GP's reluctance, Emilia insisted on a referral, where doctors discovered uterine scar tissue and damage that ultimately prevented her from safely being able to carry a pregnancy to term. She later sought gestational surrogacy abroad. And just to clarify, these are all pseudonyms, so I'm not giving away the identity of the people who are so kindly willing to share their stories with me. But unfortunately, Emilia's story was not unique. Bugewa, for instance, told me that her gynecologist had forgotten to refer her. Carol was told that she was nagging and asking too many questions. Ijioma's team dismissed her fears about the potentially life-threatening consequences of yet another miscarriage, and Adele couldn't even get a referral. When she went to her GP after changes to her menstrual cycle in her late 30s, she was told to come back when you're trying for a baby. Florence is another person I'd like to talk to in a bit more detail, and I think she sums up the consequences of these delays quite succinctly. After experiencing what she called show-stopping periods from the age of 11 to finally receiving an official diagnosis of endometriosis at the age of 35, a diagnosis that had required badgering her GP, she told me, I feel that that lengthy diagnosis has robbed me of the opportunity of being able to have a child naturally, or that is biologically mine. When women were able to convince doctors that they needed treatment, this sometimes came with a dose of racist stereotyping. As Florence quoted in the previous slide, she was in her early 40s and in the fourth year of fertility treatment at the time of the interview. Her story reflects what medical sociologists and anthropologists have identified as a common stereotype in healthcare, the belief that Black people have higher pain thresholds than other groups. During an ultrasound, Florence plucked up the courage to express that she was in pain, but the doctor dismissed her. You should be fine, you can take it. Another quote from Carol, who was on a break from fertility treatment when we met. She recalled the doctor who jokingly expressed surprise that she had been diagnosed with endometriosis, which left Carol shaken and angry. The doctor had said, "How come you've got endometriosis? I thought it was only white women that have endometriosis. Black women usually have fibroids." So, to return to the question, why do some patients fare better than others? The interviews that I held with women who had experience of fertility treatment definitely emphasized the need for greater fertility awareness. If I knew then what I know now was a very common refrain. This was also emphasized by the fertility professionals that I interviewed, with some of them working to develop initiatives to help improve understanding about fibroids or endometriosis among specific communities. Many women also talked about difficult conversations with friends and family members and reported a lack of support within and outside of their communities. So these factors are undoubtedly important and require intervention. But today, I really want to emphasize that the wider context that shows up in, for instance, dismissive healthcare professionals and racist stereotyping, whether they are physically or psychologically harmful, and sometimes both, racist stereotypes have wide-reaching consequences beyond the individual patient. They can lead to patients, for example, anticipating racism and so opting out of services altogether, or lowering their expectations of professional treatment to the point that poor treatment is expected, accepted, and not challenged. My conclusion is that any initiatives that are developed to answer this key question must take into account all the factors that shape poor fertility outcomes and develop interventions that do not locate the blame for racially minoritized communities' poor experiences in their own behavior or ignorance. The question isn't just about why is it that Black communities, Black people are not coming forward for fertility treatment, but what is embedded in the systems and structures that prevents Black people from feeling like these are comfortable spaces where they can access care and support.
Our next speaker this evening is Professor Asif Muneer. He is Professor of Urology and Surgical Andrology at University College London. He is a consultant urological surgeon and andrologist at University College Hospital and chair of the British Fertility Society's special interest group on andrology. He is co-editor of the book Clinical Andrology and contributor to books including Men's Health and Wellbeing, Assisted Reproduction Techniques, and the Textbook of Assisted Reproduction.
So what I was going to do is talk a little bit about why there are these disparities in male reproductive health, with a focus on the differences with regards to the ethnic minorities as well. So essentially, what we want to know is, why do some men fail to conceive? It's not just all a case of common risk factors, and obviously, some people attribute it down to lifestyle, diet, etc. But there's a little bit more to it. So we were talking about ancestry. Well, there is some truth in that. There are obviously a genetic basis to infertility in some cases, particularly those who have non-obstructive azoospermia. So that means there's no sperm because no production within the testicles. So there is a Y chromosome, which is what will differentiate phenotypically males from females. And the Y chromosome's got a region which codes for spermatogenesis. It's called the AZF region, and you can have three components, which is an AZF A, B, and C. And if the C component is missing, you can have either very small quantities of sperm in the ejaculate or small quantities in the testicle itself, and therefore you can father a child. But the problem is that that will then end up being transmitted to the offspring. So the offspring, if they're male, will also have a similar problem. So that's a genetic basis. There's also a link between a family history of cryptorchidism, which is undescended testicles, so they didn't drop down when they were born. And this ties in with this concept of testicular dysgenesis, which is a whole spectrum of diseases ranging from undescended testicles through to testicular cancer. Because there's an inherent problem with this structure within the testicle, that will result in impaired spermatogenesis. And then obviously there's going to be certain ethnic groups which carry certain recessive genes. So you've got the CFTR, which is associated with cystic fibrosis. There's a higher prevalence in the Caucasian population. So if you've got two carriers, then you've got a 1 in 4 chance that you might have an offspring who's got cystic fibrosis. So when you look at the Y deletions globally, so the areas which are more red or dark red is where you get a high prevalence of Y deletion. So again, you can see that there is some link with regards to where your ancestry is, that you may be carrying one of these gene deletions. And you can see over here the breakdown. So there's quite a high proportion in North America, South America, and parts of North Africa as well. And there's a breakdown there of Asia itself. And it's sort of reasonably equal proportions in East Asia, Middle East, Russia, South Asia. So it feels fairly equally distributed. Now, when you look at the data, this is from the HFEA website, you can see that there are these disparities in terms of the average birth rate. So this is IVF outcomes according to ethnicity. And you can see the black population there does fare a lot worse than the white population, and worse than the Asian population as well. And then if you look at further data over here, you can see that the average age that the black population will seek first treatment is a lot higher. So obviously that will correlate with poorer outcomes, because obviously the older the female, the poorer the outcomes and the poorer the egg quality. And then the data also shows that the percentage number of IVF cycles which are funded by the NHS is much lower in the black population than the other ethnic groups which are analysed, so white, Asian, and mixed. So again, there is this disparity in the different ethnic groups, with the black population faring much worse than the others. So this is something we need to address. If you look at the literature, there's studies are mainly from Canada and America, where they've looked at different ethnicities. And you can see over here, this is a study which looked at men presenting to a fertility clinic with infertility, and you can see that African Canadian men had a higher proportion of azoospermia than the other ethnic groups. So you can see there's a lot higher, and you can see over here another study which shows that that the poor sperm counts are related to a higher BMI. And some of these studies from Canada and America have correlated the fact that the black population with poor semen quality have also got a higher BMI. And they've also offered lower socioeconomic status as well. So they're poorer, they've got a higher BMI, and they've got poor semen parameters. So they've got multiple risk factors, but when you still put in these confounding factors, they still seem to do worse than the other ethnic groups. This is UK data, which is looking at over 158,000 cycles, where you've divided it into white, black, Asian, and other ethnic groups. And the outcomes which we're looking at here is clinical pregnancy and live birth rate outcomes. And you can see that the data here shows that there's a lower live birth rate in the Black and Asian groups in that study. So, I mean, I did a project previously looking at just male reproductive health and also sexual health, and one of the things that we found was that men are very reluctant to, first of all, reach out and seek treatment. So, studies have found that almost 60% of men will delay visiting a doctor for sensitive health issues because they're a bit embarrassed. They feel that it's a loss of masculinity, and they may find that it's not discreet, and there'll be judgmental opinions. There's also this stigma associated with unable to have a child. Again, in certain ethnic groups, there's peer pressures and family pressures as well. There's obviously the whole pathways within the NHS with long waiting times and geographic variations in what the departments will offer depending on where you live. And also, there's this tendency that if there is a delay, some ethnic groups of higher socioeconomic status will be able to afford private treatment, others will not. And obviously, we have to look at deprivation areas to see which ones will have a higher deprivation areas, which are unlikely to seek treatment until it's too late. So, so men have different outcomes because they obviously don't get treated early enough, or they don't present early enough. There's a lack of specialist input. So for something which is complicated like male infertility, particularly when there's no sperm, you do need to get specialist input from an andrology unit or someone who's got a special interest in male infertility. Sometimes obviously they can't afford the cost, they can't take time off work because obviously, you've got to look at deprivation areas, where they, just have to work every day. And obviously the local ICB rules change depending on where you live. So this is the whole postcode lottery aspect to this. So if you just look at data from England, there is data from Scotland, Wales, and Northern Ireland, but I'll just concentrate on England for now. The parameters that we use for deprivation, you can see over here, is income, employment, education, but also health. So this does obviously contribute quite a lot towards deprivation areas. And you can see on the map, the heat map here, that the blue areas and dark blue areas are the areas of higher deprivation. You can see the parts of London, the Wirral, Northeast, these are all areas of high deprivation. But the interesting thing is that apart from London, these other areas where these high areas of deprivation, they don't have dedicated male fertility units within the urology department. They have a general urology department. A lot of them will not have anyone who's dedicated to male infertility. So another compounding factor here is if you look at the NHS waiting times now, 7.4 million people waiting. This is October 2025. There's 172,000 waiting more than a year. But remember, this includes people who've got more urgent conditions, and male fertility, unfortunately, is considered a very low priority. So they're not going to be looking out for these individuals. And by the time they get seen, it may be a little bit too late for the partner to start looking at fertility treatment. So until we sort out the long waiting list as well, what that does is that, if there's going to be a delay in getting a semen analysis, the appropriate imaging, they may need surgery, they may need a varicose repair, or they need a surgical sperm retrieval. Now, that's the most important issue, particularly those who've got no sperm. So when you look at other data, so if you look at data from around the world, there are cultural reluctance as well. So African men generally reluctant to engage. They see that fertility is more of a female problem, and the fertility clinics are only for females. There's a study here from Nigeria where 50% of men will take alternative remedies rather than seeking healthcare. So there is a cultural shift as well in some, but in a free healthcare system like the UK, there should be no reason for delay and treatment. The studies from the United States show that the concentration of sperm in the black population is lower, but it's also associated with a higher BMI and a lower socioeconomic status. So this may reflect the overall health, because we do know that semen parameters now are a marker of health and disease. So it may very well be that you need to improve the health of the nation, particularly certain ethnic groups. So I'll come to that shortly. But if you look at this is me performing a microteasy, getting sperm directly from the testicle. And you can see it's a magnified picture of the testicle internally. But this is the hospital that I work out in the NHS. We've got a dedicated andrology unit for male fertility. So we take all comers. So there is no reason for delay. And the problem that we have is that in London, we've got a couple of units who will take on patients with male infertility and investigate them and treat them. But it's not like that across the whole country. You'll get centres in, say, Manchester, Newcastle, but the rest, will tend to refer to these other centres because we don't have any issues with funding. We'll, provided the female partner has appropriate funding, we'll do their surgery. So partner needs to be eligible for fertility treatment. A lot of time patients are unaware that, these services do exist. We all put this in a clinical commissioning policy a few years ago because it's cost neutral and felt that patients can undergo treatment for surgical sperm retrieval. So these delays lead to older couples, and obviously we know that the older they are, the poorer the outcomes. This is just a summary of the NHS England policy that we led on, and it shows that if you need a surgical sperm retrieval, you can freeze it for later ICSI use, but it is a bit of a postcode lottery because there is no national. This was national policy, but it's not implemented by the ICBs. If you look over here, this is North Central London, South East London, Bath, Cheshire. They've all got different policies here. So this is the reason why it's not equitable all across the country for every single patient. So take-home messages are that we do need to ensure that male fertility assessments and appropriate referrals are done promptly. We need to ensure that men can seek out specialist units because they can insist on a referral to a specialist unit. The ICB fertility policies, again, are very variable, so they don't align with the national policy. But I think, an educational campaign in these areas, which are deprivation areas, the focus on the black population is something that needs to be addressed so that we can try and ensure that there aren't these disparities between the ethnic groups.
So our next speaker this evening is Jonathan Luwagga, and he is an advocate for male fertility awareness, and he is an ambassador and peer advocate for the charity, the Fertility Alliance.
I'm not here to give any data, but I'm here to kind of just to give a little insight around my fertility story and my fertility journey and my experiences. So basically, my journey started in early 2021. Me and my ex-partner, unfortunately, we were going through trying to have a baby, and it just didn't work for us. We were trying for a few years, and then we just went to the next step was to kind of just obviously find out what the issue is. So me being naive and the last speaker said around stigma and embarrassment. I kind of just shrugged it off around my own issues. I just said to my ex-girlfriend that she needs to go and get herself checked. I'm okay, nothing wrong with me. But then she went and got herself checked. But actually, the waiting time when she went to see her doctor was very long. So told her to be a year and a half. So we had to book a private gynecologist. to see what was going on. And then from then on, it was simple. It was simply put to me that, I've got a problem, I've got an issue, and she's totally fine. Her body working perfectly well. So for myself, it was kind of difficult to kind of navigate that that information I just received, and then it was time for me to actually go and see a doctor. It took me quite a long time to see a doctor. I waited maybe like 2 to 3 months. Had to be pushed. I was very much a believer of it's going to happen. Let's just wait and see. These things take time, etc., etc. But obviously, we'll try for more than a couple of years, and it obviously didn't work. So then I went to see a doctor, and I went in there pretty open. Gave me an invasive examination of my body. He looked at my clinical records and saw that I had undescending testicles. And then he said he's going to refer me to a urologist, and that's when the journey began. But actually, one key thing is when we talk about levels of care, was one thing I'll never forget is when he said to me, as I was leaving, is good luck. And I think that's always stuck with me. It's like, I don't know, that's just kind of hit I don't know how to explain it. That good luck was just like, what do you mean good luck? Like, you could have said all the best, or I don't know, but good luck was like, I'm not gonna get anything. So, and he didn't really give me no much information about what my issue was. He just said a urologist will see you, they'll examine you, and then they'll give you more information, which is totally fine. So I went to see a urologist, and I had to do a semen analysis, and I had to do a semen analysis about three to four times, which was quite frustrating, because I just thought to myself, look, if the first time I haven't got nothing, why am I bothering to keep going back and forth? But I just followed through the process, and then I ended up having to go to do a series of procedures and examinations to kind of get to the stage where they diagnosed me with non-obstructive exemospermia. And obviously that was very difficult as well. The last procedure I had was a microteasy, a sperm retrieval, and it was a successful sperm retrieval because the consultant was able to kind of find some sperm for me, which I've stored now for IVF. And that's another thing that me and my partner at the time we were discussing. We discussed around the ideas of having to do sperm donor if they don't find any sperm. And we looked around sperm donors, and we just couldn't see many organizations that actually had donor sperm for Black couples. I mean, I was a Black woman, so we want to have a Black child, so it was very difficult for us to kind of find anywhere in the UK that kind of provided that for us. So it was more so having to look abroad, in America, to get access to that. And there were quite a few organizations that were available for us, but also it was cost effective. It was very costly. I'm not saying I'm not loaded with money, but I would have had to save a good couple of years to kind of get that done. Another thing is me and my partner. So at the time, she had a child from a previous relationship. So doing IVF was going to have to be privately funded, which we were going to do anyway. But also we faced another challenges in terms of my own mental health, my own embarrassment. Like everyone's kind of spoken about socially and culturally, it wasn't. I just felt a bit of real shame having to come talk to my family, my friends, around my fertility problem. But then the more and more I kind of like spoke about it, the more and more it kind of empowered me to make people aware around male infertility, and to inspire other Black men to kind of talk about their journey. recently, we spoke, the last speaker, Dr. Asif, Professor Asif spoke about, outcomes in Nigeria in terms of the fact that other men 50% seek different ways on, having to, having to avoid having to do IVF due to financial limitations. And that's the same thing that happened to me when I went to Uganda. I went to Uganda to kind of see how culturally men are affected by um, um, fertility problems. And unfortunately, a number of men don't talk about their fertility problems. A number of men allow their women to go to do fertility treatment in Uganda, which is very costly as well, just for the sake of the fact that they don't take the blame, and a woman takes the blame, and they're going through all these examinations, doing all these tests, really for nothing when it's the man's to blame. And the ideal for me going back to Uganda was to speak to a number of urologists in Uganda, speak to consultants, to kind of understand how we can get men to speak more around their fertility journey and to have spaces where they can be open to discuss their fertility, rather than having to hold back and obviously allowing a woman to take the blame for the fertility. And for myself, being in the UK and working with the Fertility Alliance and setting up a group, there's a group of us in a WhatsApp group actually, a number of black men, and we're in it and we all have the same issue as such. And it's been nice to kind of know that I wasn't the only person, because when I was going through my fertility journey, that's how I kind of felt like I was alone. Like there was no other black man that was going through it. But lo and behold, there's a number of men that go through it, and they just don't have the resources to kind of talk about it. Also, and in education, and you know, uh, in the discussions that we've had, on discussions of things that I've learned amongst my peers and my community, is the fact that straight away you have to go through IVF is costly, which is fine. But a number of people don't know that, okay, yes, you can go and do get NHS funded, but obviously that's a lottery, and a lot of people don't want to do that. Age as well. A lot of people in my community having kids older, so there's going to be more issues across the board. Like for myself, I'm still having to. I know that I'm going to be going through the IVF process at a later date, but I'm actually mentally and physically and financially able to kind of now support myself and be able to know that I can get through that IVF journey, whether it's funded or not. Even having to look abroad, to go abroad to European countries to find where outcomes could be better for me. So that's a bit of my story, and yeah, the main goal is to kind of just to find a space and to find education, and to stop the stigma around male fertility, especially around black men, and to find better support, and to stop the social stigmas for the fact that because a black man can have 20 kids, just because one black man can have 5 kids doesn't mean the next black man can have 5 kids. I mean, that's what I kind of felt like as well. It's like, because I'm a twin and I'm from a big family, there's real pressure on the fact that I should have, loads of kids, but unfortunately that's not the case for myself. So it's kind of just trying to break those stigmas and trying to allow men of color, and not just black but Asian as well, allow them to kind of not feel shame and not feel embarrassed around their fertility journey, and to know that it doesn't define who they are and what they are, and the only thing that defines them is just the fact that they're able to accept who they are and progress in life.
We're going to move on to our next speaker, Dr. Edmond Edi-Osagie, and he is Medical Director of Aurora Reproductive Healthcare, and he's a health education volunteer at the Caribbean and African Health Network. Previously, Edmond was the Director of the Reproductive Medicine and Surgery Service at St Mary's Hospital in Manchester. Edmond is a contributor to the recent report Breaking the Silence: Fibroids, Black Women, Time for Change, and contributor to books including Clinical Reproductive Science and Models of Care in Women's Health.
So much work has been done by HFE and other bodies looking at this, but there is still a lot that we just do not know about what's going on and a lot we need to do. And I'm really grateful for the speakers that have gone before me because they've set the scene nicely for me. I'll just go straight in to introduce the concept of reproductive justice. And reproductive justice, the tenets of reproductive justice are that a woman should have the right to have a child if they choose to. They should also have the right to not have a child if they choose to. And if they choose to have a child, they should be able to parent that child in a safe, healthy, and equitable environment. And if we look at the reproductive landscape in the UK at the moment for women, it's quite clear that we just are not achieving those tenets of reproductive justice. And people have talked about reproductive injustice, where women choose to have children, but they are impacted by so many issues along the way. And most of those issues are beyond their control. And I'm happy that we're exploring some of those issues. So I will just highlight some of the issues that pertain to women along that journey. We must start by looking at age, biology, and the two big issues are age, biology, age of the woman, and ethnicity. And ethnicity is interesting because everything else that you can see on this slide actually impacts on ethnicity. So medical comorbidities that impact on fertility, impact on ethnicity in a way, body habitus, access to care, environmental lifestyle factors that we've all talked about, all impact on ethnicity. So I'll just see if I can unpack this as we address them. We all know the impact of age. Fertility peaks in the mid-20s, starts to decline from 30, and by the time a woman gets to the age of 40, her fertility is declined to less than 10% fecundity a month. And the main reason for this is because women do not produce any eggs in life. So every egg a woman has is deposited in her body before she's born. And the estimates suggest that women have 2 million eggs at the time of birth. By the time they get to the age where they start having periods, that number has decreased to 500,000. And that's all the eggs a woman will ever have. So as those eggs are depleted, fertility declines. And this is reflected in the findings which Professor Nargund briefly showed us, that as women's age increase, the chances of having live births from IVF decrease significantly. And this impacts on ethnicity. We have studies from, as Dr. Nargund has illustrated, from HFA here and from across the Atlantic in the United States that show that African women of African descent have the worst fertility outcomes, with fertility outcomes of IVF decreased by up to 30 to 50% compared to Caucasian women. And there are various reasons why that happens. But one reason I want to highlight is that we think that there is a genuine biological reason why this happens. Because when we look at the outcomes of frozen embryo replacement treatments, women of African origin also have a poorer outcome, but only if those cycles are natural FET cycles as compared to medicated FET cycles. So in cycles where women ovulate themselves, develop the lining of the womb themselves, the outcomes are poorer compared to cycles where they are medicated, where the outcomes are not poorer. So that points to the fact that there's a genuine biological reason for this. And we also know that miscarriage rates are also higher in women of African origin following IVF treatments. Well, I'll come back to the actions in a minute. If we move on to body habitus, so we know that women, extremes of body weight impact negatively on fertility. So BMI greater than 30 or BMI less than 19. And the reason for this is that excessive body fat leads to chronic inflammation and oxidative stress, and this can negatively impact egg quality, embryo development, and embryo implantation. And interestingly, women of African origin going through IVF treatment have been associated with a higher BMI levels compared to Caucasian counterparts. Similarly, medical comorbidities, so things like endometriosis, adenomyosis that cause implantation, they decrease the chance of pregnancy. The metabolic syndrome from diabetes mellitus, from PCOS, hypo and hyperthyroidism, they disrupt implantation and they lead to a decrease in chances of conception. Pelvic masses like uterine fibroids, structural abnormalities. And when we've looked at, when studies have looked at the proportion of these conditions impacting different women, they actually have higher proportions of these conditions in women of African descent, also compounding the reason why ethnicity is important. Similarly, environmental, lifestyle factors, the substances called endocrine disruptors, things found in plastics and cosmetics, pesticides, that can interfere with the function of hormones, especially estrogens. So they mimic estrogens and they interfere with the hormonal balance, and those can impact on fertility, air pollutants, heavy metals. Interestingly, studies have found that women of African origin tend to belong to the higher exposure group compared to other women. So you can see how all of these factors compound to lead to a greater impact on women of African origin. And the speakers that have gone before me have talked about access to care, limited funding for IVF. Dr. Nargund talked about how women of African origin face a significantly higher decrease in NHS funding for fertility treatment compared to other women. They've highlighted the long waits for treatment, expensive cost of treatment, so that people who are in higher income brackets are better able to afford access to care. And we know that women from an African origin tend to belong at socioeconomically disadvantaged. And we talked about the stigma associated with fertility, and this impacts how women can access care. And just to give you an idea of how these costs can skyrocket, as women get older, you can see that the cost of treatment with IVF will significantly increase, and women of African origin are accessing IVF treatment on average about 2 years later than women from Caucasian counterparts, and this cost can be quite prohibitive to them. So looking at all of this, what can we do to achieve reproductive justice, which is the basic right of every woman? We've talked about research. There needs to be more research into the biological effects of age, ethnicity, comorbidities, and we've tried to introduce individualized protocols for IVF treatments and to eliminate comorbidities. The NHS waiting list at the moment for gynecological conditions is quite long, and I think we need to be looking at ways to bring that down. Improve access to care. We've talked about the barriers women face accessing their GPs and getting their GPs to refer them to secondary care. Expand capacity. There's still many centers across the country where access is limited to 1 IVF cycle per couple. And the concept of culturally sensitive healthcare delivery, especially when it comes to reproductive health. There are cultural sensitivities around reproductive health, and I think all those need to be researched into and brought into the mainstream of how we deliver healthcare. So education is key to both patients, carers, and policymakers, so that we can all come together and improve equity in the way we deliver reproductive healthcare, so that women can have confidence in the process and help to remove stigma, improve the safety of the process for women.
Let's move on quickly then to our final speaker, Yvonne John. Yvonne is an activist and author of the book Dreaming of a Life Unlived. She's a contributor to books including No One Talks About This Stuff and Still Hot.
So I want to begin by naming something that often goes unspoken. So for many women, fertility is not abstract or academic. It is deeply personal. It lives in our bodies, our relationships, and our imagined futures. As mentioned, I am Yvonne Hector-John. I am author of Life Unlived, and I'm also a facilitator of the Gateway Women Reignite Weekend, supporting women who are childless by circumstance. I'm also a Black woman who, at 43, after a year of fertility investigations, was told I had unexplained infertility. There was no explanation, no reason why I couldn't conceive a child. Just 2 words that turned my world upside down. I was, however, told a number. I was told that I had 4% chance of conceiving if I wanted to try IVF. Because of my age, I was far too old for NHS-funded treatment, and I couldn't afford to pursue this privately. What did stay with me wasn't just the number, it was how late in the journey I was being told this. So when we ask why women fare better than others, I want to offer this. The answer begins much earlier in how women are listened to, believed, and responded to within the medical system. By the time I eventually saw a fertility consultant, I had already spent years navigating symptoms that were treated as inconvenient rather than concerning. From my 20s into my 40s, I experienced heavy bleeding, extreme pain, to the point where I was overdosing on painkillers just to function throughout the day, as well as severe anemia. These were framed as unfortunate, but normal. I was expected to manage through my pain, to endure my symptoms, and simply to learn to live with it. When I didn't have language for it, what I didn't have language for at that time was how disorientating this felt. To be in that much pain, asking for help, and repeatedly being told to wait. At one point, I had to even lie to my GP to get a fertility referral. And once I entered that system, I waited months between tests, months between appointments, and months between answers. There was just no urgency. No sense that I was a woman in my early 40s at a point where time mattered. No acknowledgement that Black women are almost twice as likely to experience fertility issues, and no recognition that female fertility has a deeper decline in our 40s. When I began reading the research into this, I realized that my experience was not unique. I mean, come on, did you know that Black women are often seen as hyperfertile? Yet we are more likely to experience fertility issues than white women. We are less likely to be referred early and less likely to access or even complete fertility treatment. These differences are often explained as biological, but far less attention is given to delay, dismissal, and disbelief by medical professionals that we encounter. There is also the long-standing myth that Black women have a high tolerance to pain, thanks to the godfather of gynecology, J. Marion Sims. And that myth has consequences. It shapes how symptoms are heard, how seriously we are taken, and also how quickly action is taken and followed up. I experienced this when I sat in front of my GP, almost begging for help to manage my extremely painful periods, only to be met with, well, maybe it's your age. I never received the help that I was so desperately looking for. Our bodies do not exist in isolation. They carry not only biology, but history shaped by stress, environment, access to healthcare, and whether our concerns are believed or even just simply brushed aside. For me, that history became evident over time. It showed up as a pattern, one that was translated into delayed care, when my fibroids were described as just something Black women get, when my heavy bleeding was endured for years without escalation until I reached the point of needing monthly iron infusions, when my fertility was not treated as time sensitive, and at 42, I was told I hadn't been trying long enough naturally to be referred to a fertility consultant. By the time I was diagnosed, the delay itself had already shaped what was possible. Valuable time had been lost. Years of unmet needs had already passed. I mean, the most compassion I encountered came from a consultant who encouraged me to consider donor eggs, reassuring me that the baby would be mine because the donor would look like me, that my husband's sperm would be used, and that the baby would grow inside of me. It was if that all I simply needed to hear was those wording to make myself feel better. Not long after that, at 45, I was offered a hysterectomy because of my fibroids. In my late 40s, I was diagnosed with adenomyosis. But by then, I was told my womb was too diseased for anything other than its removal. I felt like my womb was an inconvenience to be discarded without a second thought. What struck me wasn't just the language, it was the timing. After years of managing pain, normalizing symptoms, and delaying care, the only option left on the table was final. This wasn't a sudden crisis, it was the consequence of years of delayed listening. After another part of my story speaks to trust. Many women of colour cautiously enter medical spaces, unsure whether they will be believed, judged, or subtly blamed. I remember a woman once telling me that she wouldn't tell anyone what was happening, not even her family, because she was too ashamed. Women of colour are often assumed to be responsible for fertility issues, as you've already heard, within relationships, regardless of where the medical causes lie. Infertility also remains a taboo in many Black and Asian communities, layered with silence and shame. That silence doesn't mean absence of pain. It means our pain is carried alone. So when women disengage, delay, or stop pushing, it can be interpreted as lack of engagement. But what if it's about whether the system feels safe enough for us to keep returning to, especially when each visit feels like another reminder that we are not being heard? My story isn't about something I lacked or failed to do. And it's not about me not wanting something badly enough. It's about what happened when my pain was normalized, when urgency was withheld, and when I was not believed early enough or at all. If we truly want to understand why outcomes differ, we must widen the lens with earlier listening, with belief at the first point of care, with accountability for delays in women's experience. Because our ancestry is not just something we inherit, it is how we respond to it. I was reflecting on Jonathan's presentation because I think it's huge and brave to speak about our own experiences around fertility and infertility. I have experienced my ex-husband talking about the shame around not being able to conceive and being, as a Black man, because we grow up with the narrative of being hyperfertile and Black men having loads of children. So when a Black man isn't able to have a child, there is a lot of shame. That's not just being carried, but also being given, because it becomes, what's wrong with you? And therefore you're not a man because you weren't able to father a lot of children. So, listening to Jonathan's story and journey and experience, I felt very moved and privileged to have witnessed that, because it's not a space many Black men are going to talk about anyway. So, I think it's very important that Black men are out there speaking, and I do commend you for doing that as well.
The first question I'm going to take is from Lorna Phillip, and she's asking, how are we defining Black patients? And she wants to know whether dual heritage patients are included in these stats. Now, I don't know whether anyone knows about how the HFEA are counting people, or perhaps people who work in fertility clinics know what boxes that are available for them to tick to send into the HFEA, so to speak, when they have to submit data. So is that something that that perhaps you, Edmond, could look at in the first instance? How is that stratified at the clinic level when you're submitting that data to the HFEA?
It's an interesting comment. I think over the years the boxes have actually expanded, as we all know. I think maybe anybody who's been involved in this journey 20, 30 years ago, we just had maybe 3 or 4 boxes. Now we have probably over 15 boxes that people have to tick. But I'm not quite sure how they're aggregated, because we have different boxes for Africans of African origin, Afro-Caribbeans, mixed heritage, evolving African. Well, I don't know how the HFEA categorizes them to put them into different categories.
I just wonder whether, Patricia, in your research, you'd asked the HFEA about that at all.
So I hadn't, although in the data that they have available online, they do have a category for mixed, but what that comprises of, I wouldn't be able to say in more detail. But I do think it's a really interesting question, and maybe even in terms of the broader way that we talk about these issues, the difference between race and ethnicity, and whether talking about these groups, all groups who are not white in one area, is a productive way of thinking about some of these differences, because as we've seen, when we kind of disaggregate the data, there are differences within different minority groups, and it's worth thinking more carefully about the language we use when we're talking about these issues.
Great. And then another question, which is in a similar vein, is, are the cohorts matched by age, BMI, smoking, location, to isolate the ethnic effects? So I suppose that's, there are two ways we can look at that, aren't there? One in the HFEA data, and then in other studies. So I don't know who wants to go first on that, whether Patricia or Edmond might be best on that. So Patricia, do you know?
Well, again, I wouldn't be speaking to HFEA or even necessarily medical data, but in a lot of the social science data that I examined in preparation for the pilot study, there are always efforts to ensure that race and ethnicity is isolated. So to make the argument that even in situations where the person has a higher BMI, or they're a smoker, or there are other environmental stresses, what the data tells us is that even in those situations, it is racial difference that seems to make a difference to people's likelihood of success following fertility treatment.
Edmond, did you want to come in on that?
Yes, I would just comment that from the data that's available, that I'm familiar with, all of these factors that I'm highlighted in my presentation seem to impact on fertility. So BMI impacts on fertility. So the higher your BMI, the less your chance of achieving a live birth. Exposure to endocrine disrupting chemicals impacts on fertility. Comorbidities impact on fertility. But in all of these, when they are actually disaggregated and they are actually looked at from a racial perspective, the impacts are always greater in women of African heritage compared to women of the Caucasian heritage. So there seems to be something that exposes women of African heritage to a greater risk of an impact from those factors. And I think that's where we just need to look carefully at what those factors are. We know that, as I said, there is some suggestion that there's some basic biology, because if you look at ovarian reserve, for instance, we can measure AMH levels across different racial groups at different ages. And consistently, the studies have shown that AMH levels are lower in African women by about 25% compared to Caucasian women at the same age. And that's just pure biology. So there are lots of things that we need to look at and understand about what's going on with all of these influences.
And Asif, what about in the male cohorts, the studies there? Are those things stratified so that you can sort of compare like with like?
Yeah, and I mean they normally just classify them as black, Asian, white, and other. Now, other could be those that didn't want to put down what their ethnicity is, or it could be, mixed race. We're not entirely sure. And I mean, some people don't fit into any of that, you see. So, I mean, Asian in the UK has a different meaning to Asian in North America. So where do sort of Far Eastern, Southeast Asians go? So, I think it does need to be fragmented properly, and I think you need more accurate data. And now that we've raised all of these, and some really good points have been made, and some alarming stories, and the discrepancy in healthcare within the same healthcare system, it's an opportunity to do it. And I think it's time that we look at this. There's a lot of talk about it, and yet I don't see anything proactive going on. And as I said before, in a free healthcare system that we all contribute to, everyone should be getting the same treatment.
No, absolutely. I abandon my neutral chair position, as I often do, and say yes. There's been a lot of talk over the years, and not a great deal of action that I've seen. It may be that there are initiatives that I'm unaware of, but it's people normally point them out to me. So I'm going to go to now a question from Jenny Akona Mensa, who says, as discussed, there's a widening body of evidence of reproductive and fertility treatment inequalities. What public health interventions are needed to improve outcomes for global majority people? And she asked lots of questions, actually, but I think I'll go with that one first of, if there was one public health initiative intervention to improve outcomes, which one would you pick? So, okay, who wants to go first on that? I don't know whether it's easier to go first or last on this one. So I'll go to Patricia, because she's smiling a lot.
Thank you. That's a very difficult question. As I think Asif has sort of pointed to, if we have a universal healthcare system, this should already be a problem that we've addressed. And so perhaps the issue is that we don't have a universal healthcare system, as it's already been pointed out, in terms of postcode lotteries, inconsistencies with access to care across levels of deprivation. So if there is one public health intervention, I'm going to go big and say properly funded the NHS.
Okay, right. Edmond?
That's a really, really, really good question. For me, I'll think that across, all the treatments I offer and all the groups I work with, the one thing that comes across mostly is lack of knowledge, lack of awareness about what these conditions are, about what women can do about it, about what treatments are available out there. I would say a massive education program starting from grassroots. I think school-age girls from the age of 15 should receive reproductive education. They should know what ovarian reserve is. They should know what AMH is. I think women, when they get to the age of 25, should be offered an AMH assay that just gives you a snapshot of what your ovarian reserve is, and it helps your future reproductive planning. I think healthcare professionals lack knowledge of, reproductive landscape and what they can do to help women. So I feel, for me, it would be education. I think massive education across boards and, with all its facets.
Great. Asif, what would you like to see?
Yeah, no, I agree. I mean, you can start off with public education programs. That's fine. But from the accounts that I've heard, and I know, I've heard from other sources as well, the healthcare professionals need proper education as well. I mean, with some of the presentations you've seen preconceived racial stereotypes, the sort of language that's used, the whole issue about, the analgesia, the lack of analgesia in certain, black women. And I mean, it just shows that there's this, kind of lack of education that continues to go on. And unfortunately, within the NHS, with it being such a big organization, it's not, just the sort of variation in treatment amongst the patients depending on their ethnicity. It's right from the top down. I mean, if you look at, the leadership models, look at positions of influence, etc. there's underrepresentation from black and ethnic minorities all across the board. So I think the whole system needs to be looked at from within, and that way, anyone who walks through the door should be treated just like anyone else equally.
And Yvonne and Jonathan, Yvonne, what would you like to see?
I mean, it's definitely twofold, as has been identified from my experience. I remember at some point on my grief journey, I realized I would say, how comes I can find out all this information, but the doctors I was seeing didn't know. So there is a real piece around education, as it's been said, in terms of the medical system, understanding fibroids, understanding endometriosis, adenomyosis, how they disproportionately affect Black women. And I'll just speak for women because I'm talking about my experience. I'll let Jonathan speak for his experience as a man. The other part to this, and I'm reflecting on what you said at the end of my talk, Sarah, in terms of being able to advocate myself, I couldn't advocate for myself. I did not have the language. I did not have the knowledge. I mean, when I was going through it, I was just reliant on doctors helping me and getting angry and upset that they weren't. It wasn't until further along when I was then starting to speak about it and doing research, I realized what I was experiencing. So there is a big piece around us being educated so we can advocate for ourselves. But if we don't know that, we're not going to go in the system to do it. So we need to understand our bodies. We need to understand what may happen to us. We need to understand fibroids, adenomyosis, endometriosis, what we should be asking for when we are in front of the GPs and the consultants, and what our rights are, what can we expect. There is, as I said, it's twofold, and there is a lot that I believe we need to do so that we can be in those systems and push and get the help that we are looking for.
Yeah, no, that's, really, I'm really pleased that you pull me up on that, actually, because that is one of those things that is the benefit. You become educated through, not through choice, but through necessity, for your own well-being and sanity, actually. Jonathan.
Yes, same. I totally agree with what Yvonne just said. In terms of the male, understanding, how does understanding testicles affect me? I wish I had known how much, all those years when I had understanding testicles at the age of 11, how much it would affect me later on in my years, in my early 30s. And also allowing men to kind of understand the semen analysis. Unfortunately, I wasn't lucky enough to kind of be able to produce any semen. So, but those that can produce semen, understand what does it mean, or if it's very low, how can they improve it, or so what lifestyle factors can be done. So when I was going through the same journey, going for a semen analysis and then being told, okay, just come back to do another one, 2 weeks later, but without giving me no information on how I can maybe improve, that could have given me a bit more hope. And also having to do my own research, having to go look and taking these, eating more, watermelon and pineapple and stuff like that, and how that's going to help me. But then I'm not saying that that they should be giving that information to you, but it should be a little bit readily available. Even just some questions and answers on a little leaflet in clinics just to help men. I know we're missed out of the conversation, so just having that available could just ease the stress of having to go in, even just doing a semen analysis. So so the education part is massive, 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 massive for me as well. If I knew certain things, so it'd be important, just to go into schools, like Dr. Edmond said it, go into schools, start young, go to schools, and allow young boys actually to make an informed decision on their life.
Yeah, the British Fertility Society has done some sort of animations and things that schools can download about fertility education. It's not specific, aimed at any specific groups. It's sort of neutral in that regard, but it is something that is good. And obviously we've got Asif here, who's on the Andrology SIG, who could think about whether the BF, advising the BFS that actually this could be a good initiative for them to take forward in terms of having something like that can be rolled out for all clinics or BFS members to have in their clinics. So that could be good. So yeah, Jenny's got lots of other really good questions, and she does say, oh, about, are we going to get to how do we get to GPs? Well, we'll have to try and use the person who spoke in our intro video, Dr. Claire Gerarda, who's now in the House of Lords, to try and get her to push forward there. She's she's a GP from London, so she's used to dealing with diverse communities. So I think we could have an ally there, and also with Professor Geeta Nargund now being in the House of Lords as well, we've got another ally that we can try and get this more into the policy area. Now, there's been some discussion between various people, Pauline Barrett and Lorna Phillip, about trying to improve egg and sperm donation for Black couples and Asian couples. There's been talk of an awareness campaign, etc. I mean, I think it'd be interesting to know, what the panel think, and I'm perhaps interested to hear from Yvonne and Jonathan first about how to reach, those communities more effectively, because sometimes I've seen some of these campaigns, they can be a little dry. They never know where to put them. It's quite difficult, because sometimes they're like posters in chemists, or sometimes they're leaflets in hairdressers. Where would you go if you were, advising someone how to run one of these campaigns to try and reach people to donate eggs or to donate sperm? So, Jonathan, what do you think? If you know?
I mean, that's a difficult question, but actually, I think it's more. I heard it doesn't sound crazy, but I think you need to go to where the majority of Black people may in the community where we may so congregate as such. And I would say maybe, I know obviously you have to be culturally and religiously sensitive, but even just church, going to church and talking about, getting someone talk about to give a testimonial or such around their fertility journey, and and not forcing people, but allowing people the opportunity to go, okay, so how can I help my community? That's one thing I could think of, and also talking amongst peers, setting up a group where people can come and discuss and then learn more about sperm donation, egg donation. That could also be quite effective. Yeah, those are just two main things that can come to the top of my head. Don't know about, maybe Yvonne might have something different.
So yes, it is a difficult one. What sits with me is the stigmatism around infertility, fertility and infertility, that makes it hard to answer this question, because I think the resistance starts way before making that video and publishing it. Now, from my experience of women I support, other forums I've been in, culturally, we don't talk about sex. We don't talk about fertility. Yeah. I remember on part of my grief journey, and I'll say this to women when I'm supporting them, is I never heard that this might not happen. So when our narratives are about, one, don't talk about your problems outside the home, and especially don't talk about certain things, it's a shame, because we are carrying shame of our ancestors in these conversations. So when we're sitting with that, even if you put those videos in the so-called right places, people are not receiving it, because they're sitting with all the negative, all the stigmatism that is saying, that is not me. I'm not going to go there and get that help. I'm not going to go and help. When I think of church, I've seen a lot around the church. And again, I'm talking from a place of what isn't helping is that when you've got the religious aspect of it and it's turn it all to God, no one's going to be listening to those videos. I've been in the church where IVF is seen as not of God. So until we are opening up these conversations and breaking down the stigma and normalizing it, I don't think it matters what happens. I just think there'll always be that resistance because we're holding on to those preconceived notions that this is not right, this is not the right way.
Does anyone else want to come in with any thoughts about how a successful campaign could be made?
Can I just add a little bit to that? Because I've got some experience of this. About 15 years ago, when I was setting up my private fertility service, one of the things I was really interested in was to try and see if we could improve the recruitment of ethnic minority egg donors. And I spent every other weekend visiting a church community forum, a women's community group, different groups to try and speak to them. I went to several, and everywhere I go to, there's good reception to what I say. There's a line of people who are interested. We take all their contact details, and then over the ensuing, the following weeks, my secretary tries to get in touch with all of those people, and eventually it all dries up and nobody's interested in actually progressing. So I go back to what Yvonne said. I think the problems actually start way before, and I think there are cultural beliefs, there are stigmas that we just need to break down, and it comes back down to education. I really think we need to understand what these things are, educate people, let them know that, this is a service similar to just giving blood and, helping your fellow being. I really think, for me, I think education and getting right down to what form of culturally sensitive education can help us achieve this is the key.
Asif, did you want to comment, or should we move on?
No, I mean, I'll just echo that. I mean, it's it is a difficult situation. Just going on to, campaigns, etc. I know you sort of alluded to the BFS campaign. I mean, the testicular animations is about self-examination. It's more focused towards testicular cancer, but it does also include all the anatomy and, you sort of educational. But the question is, how do you get all of this out there? But I think that the good thing that we have now is obviously a lot more people engage with social media and a lot more people engage with AI. So, routinely now I'll get patients coming in who have looked up their conditions on AI, and they'll know these terms which were a bit alien to everyone beforehand, and an explanation, and that's why they can come in a bit more informed. So I think as that, carries on and people get more and more informed, I think it will lead to better outcomes in the long term.
Yeah, I think that's a really good point. So I'm just trying to find one last question. We've got a few, and we're running out of time now. I think I'm just going to go to you, Asif, for the final question, because someone's put it in a sort of few different ways. Do you think there's insufficient testing of male issues in fertility clinics? Do you think that there's a sort of, or well, perhaps not in the fertility clinics, perhaps at GP level? I think in the first instance, is there too much the view that this is a woman's issue still?
Yeah, I think it's a good point. I mean, obviously, every fertility clinic is going to be different. Some will place a bit of emphasis, some won't. Generally, though, you're right. I mean, I still think there's perception that it's a female issue. The men, are a bit of an afterthought. So routinely, we'll see women going through treatment investigations, and no one's considered, just checking the male side, because a lot of the time the focus is on, oh, if they've got sperm, then that's what we want. But what they miss is, surgically reversible causes of male infertility, which there are, surgically reversible causes. Some people can be obstructed, some people can have prostate, congenital cysts, so that's why they've got no sperm. All of these little small, I mean, they're not high proportion, but they're reversible. So it avoids them having to go for an unnecessary sperm retrieval, find some sperm, go for ICSI treatment, pay, an arm and a leg. A lot of these people, are scratching around trying to pay for their treatment. Whereas, if they were assessed properly, they could have a procedure which would surgically reverse their problem, and they could have a natural conception. Also, often the couples have multiple failed cycles, and then no one's again examined the quality of the sperm, or can they improve the parameters on the male side. Again, it's quite costly, and then you find something that needs to be reversed, like got a big varicocele or whatever, and then they get better outcomes. So yeah, unfortunately that is the case, not just here, but it's globally, it's the same problem.